in preparations of the World Lymphedema Day, which is coming on the 6th of March this year, and it's going to be hosted at Kenyatta National Hospital. This webinar series, they're going to be running every Thursday, and the first week of March on the Tuesday of 3rd. So the people you're seeing displayed here, they are your teachers, your presenters, and your instructors from different parts of the world. And the first one is going to be anatomy and physiology from Susie Davy, who is certified lymphedema clinical instructor from South Africa, and also my teacher. And I am going to be doing the pathophysiology and classifications of lymphedema. So let us stay on until the class is finished. We will answer all your questions at the end of this. Dr. Cedric, I think we're good to go. I think I'm going to request the host to drop the screen so that we can share ours. Thank you.
All right, you're going to be sharing. Okay. Great. Perfect.
Able to see my screen?
Yes, yes. It's visible.
Just gonna turn it to slideshow. Just a minute. Oh yeah, that's where we start. Susie, I think you're good to go.
Great. Thank you so much, Janet. So I am very honored to be speaking today on this topic of lymphedema awareness and proper management, the webinar series. We are here today because of Janet and the rest of the team's effort from the hospital, Kenyatta National Hospital. And my background is I'm an occupational therapist, but I have been a certified lymphedema therapist for over 25 years. And it was very early in my career that I realized when I started learning about this information, we do not learn this in our undergraduate degrees in physiotherapy, occupational therapy, and also in medical schools. I think it's an underdiagnosed condition. And so I hope I can bring light and some energy into bringing more awareness around the condition, why it happens, what it is, and look forward to presenting to you today. I am from America originally, and of course, for the past 13 years, I've been living here in South Africa, and I have become the clinical instructor and certified lymphedema management certification course instructor, and have been teaching for the past 10 years, and have certified over 300 students throughout South Africa, as well as Southern African countries. And in 2023, we launched the first lymphedema certification course to 14 physiotherapists in Nairobi, Kenya. So can we go to the next slide? Janet. Thank you. So we're going to touch upon the lymphatic system, anatomy, and physiology first. You can go to the next slide. So what is lymphedema? Lymphedema is a long-term condition causing swelling. And this can occur for a multitude of different reasons, but it basically is when the lymph system does not drain properly. And it most commonly affects the arms or the legs, but really lymphedema can occur in any part of the body. It occurs in head and neck from different types of head and neck cancers. It can occur in the trunk, in the body, in the back. Really, any part of the body can be affected by lymphedema. And overall, the most important aspect is that it can affect the daily quality of life if it's not managed early when the swelling first begins to happen. We can go to the next slide. So what does lymphedema look like, right? It can happen in the arms, typically after breast cancer, but it can happen in the arm from different traumatic injuries and different things. And then, of course, in the lower legs. And it occurs for a variety of different reasons. This example, these are actually Janet's patients from Nairobi. And in both of these situations, she was able to manage these conditions, make the edema better and more manageable for the patient. The next slide. And so here are some other examples. Janet, I don't know if you want to just pop in here for a moment just to touch upon, these are your different patients, but these are pictures of her actual patients at this physiotherapy center where she's treating patients. Do you want to just mention quickly?
Okay, yeah, so the first image right here is a photo of primary lymphedema, or what we call premature lymphedema classification for a teenager, young girl. Then this is a patient also with primary lymphedema. This was controlled. You can see they planted the lymph node right here at the ankle joint, and then we continued with compression therapy. Now, this baby here is a 3 months old with congenital lymphedema, the Klippel-Trenaunay syndrome. And this image is lymphedema tarda, and this is also lymphedema tarda. So we just put here so that you can see what lymphedema looks like.
Great. Thank you so much for sharing. And again, it just shows there's a variety of different types of conditions, different swellings, and some are very large, some are not so large. So when you see a patient, it really is so important to do a proper clinical evaluation. So we're going to explain why this happens now. So with regards to the anatomy and physiology and the circulatory system, everybody knows when the heart pumps, the arterial system pumps the blood away from the heart, and the venous system and lymphatic system is a way for blood to come back to the heart. But there's circulation of blood from arteries to the veins happens in the blood capillary bed at the bottom of this here. And the exchange of fluid from the arterial system into the venous system, this is the tiny but very important, because that's where the exchange of blood and fluid happens. And this is the area of the body where the lymphatic system begins to work its magic. So we'll go to the next slide. So there's 3 major types of blood vessels, as we just mentioned. But the important aspects is the arteries that carry oxygenated blood away from the heart. The veins carry blood, deoxygenated blood back to the heart. And with regards to the walls, they're made, the blood capillaries serve as an exchange between the arterial and venous system. And this is where the lymphatic system begins. The walls are made of single layer of epithelial tissue, and they're extremely permeable to allow diffusion into the interstitial tissues. So we'll go to the next slide. So the anatomy of the lymphatic system in that capillary bed is there's a meandering network of lymphatic vessels that runs alongside the circulatory system. And this is a schematic that shows the lymph system. Of course, we have all of the lymphatic vessels throughout the body, and then you have the lymph nodes in specific areas of body, which I'm going to talk about a little bit later in the presentation. But it's important to note we also have the lymphatic vessels, and then there's various lymphoid tissues and organs scattered throughout the body. Next. So with the lymphatic vessels, the function of the lymphatic vessels, or these initial lymphatic vessels, is to form an elaborate drainage system that picks up the extra tissue fluid that's in the interstitium. And once it enters into these little lymphatic vessels, these initial lymphatic vessels, this is where interstitial fluid now becomes and is called lymph fluid. So these are a schematic of a lymphatic vessel. They're one-way valves, and they have anchoring filaments on them. So every time you're moving and the body's moving, or we're moving the surface of the skin, these lymphatic vessels are opening and allowing this interstitial fluid to flow in. But sometimes, if the lymphatic system has been disrupted, or if a person is born with less lymphatic vessels or less lymph nodes, this is where fluid stays stuck into the interstitium, and it's not going into these lymphatic vessels, and this is where problems begin. We can go to the next. So the function of the lymphatic system is that, and there's different research to show there could be up to 30 liters of fluid that's flowing through these blood capillaries, and only 27 of the liters of this fluid is flowing back in through the lymphatic system. So if that extra 3 liters of interstitial fluid is entering into the interstitium and it's not being reabsorbed by the lymphatic capillaries, this is where edema starts to form. And remember, when edema starts to form and it sits for a period of time, then it can start to become thicker and more protein rich. And this is where then edema occurs if the fluid is not removed. We'll go to the next. So within this capillary, this endothelial cell, the green strip is showing the lymphatics or lymphatic vessels, and it's a one-way system, as I mentioned. So they're microscopic, blind-ended lymph capillaries, and they weave between the tissue cells and blood capillaries in loose connective tissue of the body, and they absorb the leak fluid. So, like I had mentioned earlier, these endothelial cells have these anchoring filaments, and they're sometimes called one-way swinging doors. And the surrounding structure gape open, and when the fluid pressure is higher in the interstitial space, it allows the fluid to enter into the lymphatic capillary. So this is one of the aspects that fluid can go into the initial lymphatic capillary. We'll go to the next slide. So again, it's all about fluid balance. The lymphatic vessels transport blood fluids that has escaped the blood capillary bed vascular system into the interstitial spaces. And like mentioned earlier in the previous slide, about 3 liters of fluid leaks from the blood capillaries into the interstitial spaces each day. So you can imagine, you can envision a 2-liter bottle of Coca-Cola, right? Everybody has seen one of those. So now imagine that excess 2 to 3 liters of fluid that is leaking into the interstitium is now not being reabsorbed for whatever reason. So this is where on a daily basis, people can start developing swelling and the body's not coping. And eventually these swellings can become worse and worse and worse. So it's really important that if the fluid remains in the interstitial spaces and it's not reabsorbed and the edema will result, this can cause more swelling, more tissue damage, skin changes eventually, and eventually they have pitting edema, and then even harder edema, something called fibrosis and hyperkeratosis can occur when you see these large elephantiasis-like limbs that have almost like tree bark looking system effects to the skin. So when this excess interstitial fluid enters into the lymphatic capillaries, again, this is when the interstitial fluid is now called lymph. Go to the next. So other functions of the lymphatic system, of course, is fat absorption. The lymphatic system also absorbs fats and other substances from the digestive tract with the lacteal or special lymphatic vessels. The fats enter the lacteals and pass through the lymphatic sites. And this houses the body's defense system as well. The lymphoid tissues or organs house phagocytic cells and lymphocytes, which play an essential role in the body's defense and resistance to disease. Next. So again, I think this is just a recap of the fat absorption. It absorbs fats and other substances to the digestive tract. Lacteals are special lymphatic vessels located along the lining of the small intestine, and fats enter the lacteals and pass through the lymphatic vessels to the venous circulation. And then, of course, the lymphatic system houses the body's defenses. The lymphoid tissues or organs and house the phagocytic cells, lymphocytes, which play essential roles in the body's defense and resistance to disease. You know, most often when you think of the lymphatic system or lymph nodes, it's the immune system. It's what filters out disease processes and viruses in the body. Hence, sometimes when you have a sore throat and you feel a swollen neck, it's your lymph nodes that are swollen. Or in cancer situations, when patients have cancer, they're always checking the lymphatic system and the lymph nodes to see if the cancer has spread because it is responsible. So the lymphatics and the lymphatic vessels are also called form a one-way system, as we mentioned, the lymph capillaries, as I've already reviewed, and then we have these little mini valves. We'll go to the next slide. And once the lymph fluid, as I've mentioned, go into those initial lymphatic capillaries, It then drains on a deeper level. And when it goes to the deeper level, this is called the lymphatic collecting vessels. Lymph is transported from the lymph capillaries through successively larger lymphatic vessels. And these lymphatic vessels are referred to as collecting vessels until it's finally returned to the venous system through one of the two large ducts in the clavicle region. But these collecting lymphatic vessels have these lymph angions, and the lymph fluid is pumped through these lymph angions and then drain into either the right lymphatic duct on the right side, drains in from the right arm and the right side of the head and thorax to the right subclavian vein, or on the left side, it drains into the large thoracic duct and receives lymph from the rest of the body. So 75% of the body empties the lymph into the left subclavian vein, into the thoracic duct. So the physiology of the lymphatic system: every second of the day, an army of hostile bacteria, viruses, and fungus swarms in our skin and invades our inner passageways. Yet we stay amazingly healthy most of the time, thanks to our body's defense and the lymphatic system. Next. And what helps us cleanse this lymphatic fluid to not cause havoc in our body is the lymph nodes. The lymph nodes help protect the body by removing foreign materials such as bacteria, tumor cells from the lymphatic stream, and by producing lymphocytes that function in the immune response. The next. So the lymph nodes, in particular, help protect the body by removing these foreign materials. And as we said, they assist with pulling out the tumor cells and by producing lymphocytes that function in the immune response. So we have our main lymph nodes in our body that we stimulate when we're treating a patient with swelling. We're stimulating the cervical lymph nodes, and lymph nodes could be here in the neck area, and this is the terminus area where all of our lymph fluid eventually drains into. Then we have our lymph nodes in the axillary area, in the inguinal area. This is actually the inguinal area is in the groin area. That arrow should be going up here. And these at the knee are called the popliteal lymph nodes. But we also have lymph nodes all along all of our organs in our abdominal area. In our abdominal area. But you also have lymph nodes along each one of your rib spaces, along your sternum, and along your spine. So these are all other areas where there's lymph nodes that help drain lymph in the body when there's an excessive amount of swelling in different parts of the body. And this is where a certified lymphedema therapist gets trained to understand and really learn the anatomy and physiology of where all of these lymph nodes are, where the lymph vessels are draining to, and understanding that you have to do a thorough assessment to find out, has a patient had surgery? Do they have scar tissue? Have they had lymph nodes removed or radiation, or even a scar from childhood that seems like it really didn't matter, but it could actually affect the way the body system drains fluid. So lymph nodes are very important in our lymph drainage system. And the afferent lymphatic vessels is how the fluid goes into the lymph node, and the efferent is how it's removed. We can go to the next slide. Great. So the size and shape, I think I'd like to point out that lymph nodes vary in size and shape throughout the body, but most of them are kidney-shaped and less than 1 inch or less than 2.5 centimeters long. And they're buried in connective tissue that surrounds them. So lymph nodes, interestingly enough, if I just want to bring this as an important side note that I learned many, many years ago. So these tiny, tiny lymph nodes, in relation to breast cancer, many years ago when they first started doing sentinel lymph node biopsies, I was told by several surgeons that don't worry, we're not going to see lymphedema in the arm anymore because we're doing sentinel lymph node biopsies. We're injecting and we're only removing one lymph node instead of removing 20 or 30 lymph nodes to check if there's cancer in the lymphatic system. But it was still interesting to note and to see in clinical setting, you're still seeing patients with a sentinel lymph node with only 1 or 2 lymph nodes removed who are still developing clinical lymphedema and swelling in their arm. And what was revealed to me by a plastic surgeon who was doing some of these sentinel lymph nodes is that when they inject the dye and they open the patient to take this one lymph node out, it's not like the lymph node is just on the surface of the skin. They still need to search through the connective tissue to remove this dye-filled sentinel lymph node. And it's in the searching of the lymph node sometimes is the disruption in the greater lymphatic system that causes the disruption and eventual swelling of lymphedema in the arm. But let's go to the next slide. Thank you. So the lymph nodes are responsible, they have macrophages within the lymph nodes, which engulf and destroy bacteria, viruses, and other foreign substances in lymph before it is returned to the blood. There's lymphocytes, collections of lymphocytes, a type of white blood cell that are also strategically located in the lymph nodes and respond to foreign substances in the lymphatic system. And then, of course, we already talked about the size and shape. And then the trabecula, which each node is surrounded by a fibrous capsule from which strands called trabecula extend inward to divide the node into a number of different compartments. And then we have the cortex, the outer part of the node. The cortex contains collections of lymphocytes, which are called follicles, and many of which have dark staining centers called germinal centers. Next. Great. And as I mentioned before, the afferent lymphatic vessels, this is where lymph enters the lymph node through the afferent lymph vessel and exits through the efferent lymphatic vessel at the ileum. But plasma cells, there are B cells generating plasma cells, which release antibodies, and T cells in transit throughout the cortex, and of course the medulla, the phagocytic macrophages in the central medulla. So it's all of these components of this important lymph node that's doing its job, keeping your body safe and healthy and keeping viruses and infections and bacteria filtered so that it doesn't cause disruption in your health. Next. Good. So therefore, the path of flow, lymph flow through a lymph node, as we mentioned, it starts in the efferent lymphatic vessels. Then the afferent vessels deliver lymph to the subscapular space and a meshwork of reticular fibers, macrophages, and dendrile cells. Dendrile cells are involved in the initiation of the immune response. And then lymph next flows into the outer cortex, which contains B cells within germinal centers that resemble those of lymphoid nodules. And then lymph then flows through the lymph sinus in the deep cortex, which is dominated by T cells. And then lymph continues into the medullary sinus. And at the core of the lymph node, this region contains B cells and plasma cells. And eventually out through the efferent vessels to bring out, and they leave the lymph node to the ileum. These are vessels collect lymph fluid and from the medullary sinus and carry it towards the venous circulation. And we'll go. Good. So what is lymph, right? So we talked about it's the fluid that enters into this little lymphatic vessel, but what is the composition of lymph? Typically, lymphatic vessels are fine as silk thread. So lymph fluid that flows through these fine as silk thread vessels is water, plasma proteins, lipids, colloids and minerals, enzymes, urea, mineral hormones, hyaluronic acid, immune cells, which would be the lymphocytes, macrophages, and erythrocytes. And then, of course, unfortunately, there's toxins, bacteria, and dead cells. But it's usually a clear, transparent, or in the abdominal area, it's a yellowish alkaline fluid, and it's slightly less viscous than blood. It's usually between 75 and 100 grams of proteins per day escape from the blood circulation, and these proteins are transported in the lymphatic vessels. So lymph production daily is between 2 to 3 liters of fluid per day. Go to the next. And of course, we just want to mention the other lymphoid organs that are responsible for our immune defense are also the spleen, the thymus gland, and the tonsils, as well as the Peyer's patches of the intestines. In this presentation, we're not going to go into detail with the lymphoid organs because we're going to focus our attention on the aspects that affect also lymphedema. So in our mechanisms of flow, I always like in whatever presentation I'm doing to whatever group of healthcare professionals, I like to point out that lymph fluid, lymph in the lymphatic system doesn't have a pump. Like our heart pumps every day and that pumps blood through our circulatory system. But the lymphatic system doesn't have a mechanism or a pump mechanism. So it's dependent on 3 things. So it's dependent on these lymphangion contraction, but how do those lymphangions contract? I'd like for you all, because we've been sitting for a little while now, stretch your arms up, pump and open and close your hands. If you feel like standing up right now, you can stand up and get some calf muscle pump as well, right? So mechanisms of lymph flow, you're moving your lymph right now. Movement of lymph happens when the muscle is pumping, and the skeletal muscle pump is super important. So if a patient is not mobile, not moving, they have to move to get the lymph fluid flowing. The second thing that really is effective with moving lymph fluid is the respiratory pump and the diaphragm. Diaphragmatic breathing, very, very important in movement of lymph through the body. So I'd like for you all at this moment, because this is what we teach all of our patients, and every one of us wants to be healthy, right? And boost your immune system. So let's put your hands underneath your rib cage on your abdomen. And I just want you to sit back for a moment and take a deep breath in through your nose. And I want you to breathe in as deeply as you can. As you're breathing in, you're expanding your abdomen. So breathe in deep. Hold it for a few seconds. And then I want you to breathe out through your mouth. And as you breathe out, you feel your diaphragm falling and a deflation of your abdomen. So I want you to breathe in one more time. Breathe in deep in through your nose. Really try to expand your abdomen. Breathe down, down, down to your belly. And then breathe out through your mouth. Now, this type of diaphragmatic breathing really helps to move lymph fluid in the body. And then the third thing that is very, very crucial and important as well, and again, as healthcare professionals, we should be concerned in all of our patients, how many bowel movements are they having per day? And you'll be shocked to find out often when you ask this question, sometimes people are only going every 2 or 3 days. It could be due to a variety of different reasons. Sometimes it's side effects of medication. But can you imagine eating 3 meals a day, breakfast, lunch, and dinner, and snacks and drinks, and then only eliminating every 3 days? Of course, there's a backup of, fluid and toxins and junk in your digestive system that then adds to lymphatic congestion. So it's really important to start asking these questions. Are they moving? Are they doing diaphragmatic breathing? And are patients eliminating the foods that they're eating in a timely manner and not keeping it in their systems too long? Very important. Next. Janet, thanks. So this is the end of my part of this talk, but Janet is going to be speaking now on the pathophysiology of the lymphatic system, and we'll still be on the call. I'm going to stay on till the end, and at the end of Janet's talk, we can answer any of the questions that you may have. And thank you so much for your attention. I look forward to, at some point, meeting each and every one of you. If you want to learn more, we're certainly always willing to talk about lymphedema and lymphedema management and awareness. So thank you for your attention.
Thank you, Susie. Thank you for a very detailed but easy to understand presentation. That was lovely.
Thank you.
So I think as Janet is preparing for her own side, maybe if we can take maybe 1 or 2 questions, and based on the presentation Susie has made. So if there's anything on the chat, I think just have a look. Yeah, if there's anything, and if you have a question or anything, you could put it down on the chat, and then we'll see if Susie can get back to all of us. So feel free to go ahead on the chat. Thank you, Susie. Lovely presentation.
Thank you so much, Dr. Cedric.
Meanwhile, we'll wait for Janet to put up her part of the presentation. So I'll ask for guys to be a bit patient as we wait. Yeah, I can see somebody has asked, but this is, I think, is the webinar CPD accredited? Yes, it should be. I think when you're signing in via the email, there's an option of asking for there's that option you get to, I think, get your license number and everything. I think the systems nowadays are automated. I'm not so sure about maybe on the physiotherapy side or on the nursing side. I would believe it's automated. So, but we'll get the relevant guys to get to answer that. I know on the doctor side it is automated, so you should be able to. Lovely, Janet, you're ready?
Yeah, I think I'm ready. Can you see my slides?
Yes, very clear, and you're also very loud and clear, or rather, you're loud enough and clear.
Thank you. Yeah, thank you for the thumbs up, attendees. So I'm going to pick up from pathophysiology and classification of lymphedema. And thank you, Susie, for the earlier presentation. That was very, very interesting and lovely and insightful for everyone. Yeah. So we're going to pick up on the pathophysiology of lymphedema, and I'm just going to be giving you just a minute. Yeah. It's going to give you one example. Okay, so lymphedema usually accumulates in the extremities most of the time, but we also have other forms of lymphedema like the ascites, hydrocele, which is lymphedema accumulation in the groin region or the pubic area. So one examples of high output lymph failure is ascites, which is secondary to portal hypertension, and it is usually associated with cirrhosis of liver. So basically, lymphedema occurs when we have either high output or low output lymph failure. So that is just one example of high output lymphedema failure. And an example of low output is lymph failure post-mastectomy edema from the resection of lymph nodes, that is removal. Now, there are four major physiologic mechanisms that cause lymphedema. The first one is increased blood capillary hydrostatic pressure, decreased plasma protein concentration, increased blood permeability. Let me move this, it's blocking my slides. Yeah, there.
Sorry, Janet, I think we lost you for a second.
Yeah, I was trying to move this is actually, just a minute. I think this works. Move this there. I think now we are good. I'm ready to continue. So we have increased blood permeability, which Susie explained earlier, and blockage of lymph return. So now the pathogenesis of this condition, we have the first step, which is lymphatic aplasia. Aplasia means basically we have missing lymph nodes or lymph supply in a particular area of the body. Either we do not have the lymph nodes, we do not have the lymph vessels supply in that particular region. Can also be as a result of hypoplasia, which means narrowed lymphatic vessels than normal, and we have valvular insufficiency, obliteration or disruption of the lymphatic vessels. So this leads to primary decreased lymphatic contractility. Now, when this happens, we have reduced, something called stasis, where we have, slow lymphatic return, and then that leads to lymphatic hypertension, decreased contractility, and secondary valvular insufficiency. Now, when we have the lymphostasis, we are going to have accumulation of lymph because the lymph fluid is moving slower than the way it should move for normal people without any compromise to the lymphatic system. Then we have interstitial fluid. Now, one very, very important thing that you should understand is that with lymphedema, the fluid is usually protein rich. And this is now what starts to cause the tissue to harden up. So we have the interstitial fluid and protein, glycosaminoglycans within the skin and subcutaneous tissues. Then these ones, when we have protein accumulated in a certain area within the body, we have stimulation of collagen production by fibroblasts, which disrupt elastic fibers and activate keratinocytes and adipocytes in the body. Now, this is what causes the skin thickening, and that is what we call fibrosis. So it's just basically what I explained, the pathogenesis mechanisms, lymphatic valvular insufficiency, obliteration of lymphatic vessels, and decreased lymphatic contractility, aggravates lymphatic hypertension and lymph stasis. Accumulation of lymph in interstitial fluid, proteins, and glycosaminoglycans within the skin and subcutaneous tissue eventually stimulate collagen production by fibroblasts, causes disruption of elastic fiber, and activates keratinocytes, fibroblasts, and adipocytes. And this results in this skin thickening and causes fibrosis of subcutaneous tissue. However, the sequence of these pathomechanisms, their interrelationship and progression vary depending on the specific etiology of lymphedema. So it's not necessarily that you're going to see this same mechanism appearing to all the patients that you receive with lymphedema. Okay, now when you look at the photo on our left side, the blue image is showing a normal flow of the lymphatic fluid. Now let's turn to the one in green and the light green image. Well, right up here, we can see the level of obstruction. Now, this is what happens. Susie earlier said that lymph moves in one direction. It doesn't have, a return mechanism because it's just one way. So when we have fluid moving up and then we have dilation of the valves with insufficiency, this is what happens. Because they have diversed, we are going to have reversal flow right here. And this is where the obstruction is, whether it is by lymph node transfer, removal, whether it's trauma, whether it's primary, whether it's aplasia, hypoplasia, whatever it is, this is what happens. And then this is where our fluid starts to accumulate, and then we see lymphedema. So in lymphedema, the equilibrium is disrupted. We have protein-rich fluid, accumulation in the tissue space. The colloid osmotic pressure rises and causes ultrafiltration, which pulls and holds water in the tissue like a sponge or dry bean soaked in water. So you imagine when you put a bean in water, how it pulls up because of the semi-permeable membranes that within that cell. So edema increases the diffusion distance for nutrients to reach cells of the skin and waste products to be removed. Now we said part of the fluid that is being carried by the lymphatic system is toxins, and they do not return back. They do not get removed from the skin. Now, when this fluid continues to accumulate, that is where we get some infections showing out in lymphedema patients. The cells in the body rely on loose connective tissue for nutrient supply and water removal. Now, these are the classification of lymphedema. We have two major classifications. We have primary, which is an inherent defect, and then we have secondary, which is extrinsic damage. Secondary lymphedema is basically caused by what we know, something that you can say this is lymphedema as a result of one, chronic venous insufficiency, worms, filariasis, infection, surgery, and all that listed there. Now, when we go to primary lymphedema, we have congenital, aplastic lymphatics, what I just explained. typically bilateral lower extremities, lymphedema precox, hypoplasia, typically unilateral foot and calf, often in adolescence for the premature lymphedema. And then we have lymphedema tarda. This is just going to be explaining. So primary lymphedema is associated with aplasia. I mentioned earlier, it's absence of lymph supply in a particular area of the body. We have hypoplasia, which is narrowed lymphatic vessels than normal. Hyperplasia is the opposite, where we have more wider blood vessels, not blood vessels, the lymphatic vessels than normal, and obstruction of the lymphatic vessels. And there are three major categories of primary lymphedema. The first one is the congenital, which is noted early in infancy, between 1 day and 2 years of age. Then we have lymphedema precox or lymphedema tarda. Most onset of this edema is actually at puberty and can take place up to 30 years of age. And the one which manifests over the age of 35 years and above is called lymphedema tarda. Now, inherited congenital lymphedema was first described by Nunn in 1891. The following year, Milroy reported a family with 97 members, 26 of whom 6 generations manifested the phenotype in the neonatal period. And inheritance was dominant with incomplete penetrance, and manifestations were painless, non-progressive, and confined to the lower extremities. So this phenotype was named the Milroy. So I'm sure most of us have had the Milroy disease. It's one of the lymphedema we're talking about in Williams Osler's book and the Principles and Practice of Medicine 1901. Now, although other cases of lymphedema with post-pubertal onset and acute cellulitis were reported by Mitch, 1898. In the early 1950s, another variety of puberty onset lymphedema, invariably associated with discharges, an extra set of eyelashes was reported by Neal and Schul in 1954. Now, although non-Milroy disease and lymphedema discharges syndrome may have other signs and symptoms, we have varicose veins. Those are some of the signs and symptoms of that condition. Ptosis, heart abnormalities, cleft palate, recurrent episodes of cellulitis, papillomatosis, and upslanting toenail and hydrocele in males. Lymphedema was considered the major clinical sign by Bryce et al. In 2002 and 2005. Now, this is what lymphedema, the primary congenital lymphedema looks like. This is a baby, an actual photo of one of our patients at KNH, a baby who is 3 months old. After the baby was born, 3 days later, the parents started seeing leg discrepancy in terms of lymph volume. And then they came to the facility and eventually they were actually directed to us. So that is how primary lymphedema looks like. Now, this particular one here is Klippel-Trenaunay syndrome, which affects one part of the body. Now, this is what happens in this condition. We have overgrowth of the affected leg. And here where we are saying pot of wine, you can see the lymphatic vessels have grown all the way, but then their absence here, and we have abnormal veins and lymphatic vessels. So the congenital malformation syndrome of Klippel-Trenaunay syndrome, that is how it shows in the earlier image. Now, this is a premature lymphedema for a 15-year-old lady, which has been successfully managed, as we even display the image here. So this is how it looks like. It starts showing most of the time, I wouldn't really say puberty, but sometimes patients come even at the age of 8 and 9, and I think 6, 7, 8, and 9, they can also show these signs. Sorry for that. And this, if someone comes to you from any age, as long as it's not 2 years and below, then that is premature lymphedema. And once it's diagnosed early, this one is easily manageable. So this is now how lymphedema tarda looks like. This is a lady who is 36 years of age. Okay, it started when she was 36. Currently, she is 43. So she does not have any underlying factors. She does not have hypertension, history of varicose veins, no history of venous insufficiencies and all that. So edema just started. It was painless. Eventually, the lymph volume started to increase, and we have also managed. So secondary lymphedema, which is the other classification of lymphedema, is associated with damage or obstruction, again, of the lymphatic vessels by infectious etiology. We have, for example, filariasis and other bacteria. We have lymph node dissection. We have radiotherapy, chemotherapy treatment, and other causes. Now, the most common cause of secondary lymphedema in the world is filariasis. More than 120 million people have been infected, and about 40 million people are subjected to serious disfigurement and disability. And that was a study by World Health Organization in 2018. In the United States and other industrialized countries, lymphedema is most commonly secondary to cancer therapies, lymph node dissection, and radiation therapy. Now, Pitrek and Healy estimated the incidence of lymphedema after breast cancer treatment from 6% to 30% in 5 Western countries. But in a cohort of breast cancer survivors examined 20 years after diagnosis, 49% presented the sensation of lymphedema and 13% had severe lymphedema. Erickson and colleagues estimated a 41% incidence of lymphedema after breast cancer therapy, which ranged from 21% to 51%, but a lower incidence of 17% in women who did not receive auxiliary radiation. Now, the effect of sentinel node biopsy on the incidence of lymphedema is still unknown, but for auxiliary node dissection, it's quite high. So this is one image of how secondary lymphedema looks like as a result of cardiovascular insufficiency. You can see these patients to have had an arterial wound, also successfully managed. We said that secondary lymphedema is the one that we know the cause. Now, this is as a result of breast cancer. These patients also have been successfully managed. So this patient in the second image right here, they did not do the surgery. They started with chemotherapy. The patient was at stage 4 breast CA, and the breast had really grown. So immediately after like the first session of chemotherapy, then we had edema accumulation. Now, those that are managing cancer patients, and especially at advanced stages, remember, do not do, I'm sure we're going to talk more about this, but do not do compression or redirection of the lymph fluid when the patient is not on treatment. And then we have lymphatic filariasis, which is commonly known as elephantiasis. I didn't just pull a photo of that. It's a neglected tropical disease, and infections occur when filarial parasites are transmitted to humans through the mosquito. So infection is usually acquired in childhood and causes hidden damage to lymphatic system. So this is how it looks. This is an image of lymphatic filariasis, and the painful and profoundly disfiguring visible manifestation of the disease, which is now lymphedema and elephantiasis, and also at other times we have scrotal swelling, occurs later in life and can lead to permanent disability. Now, these patients are not only physically disabled, but suffer mental, social, and financial losses, contributing to stigma and poverty. In 2021, 802.5 million people in 44 countries were living in areas that require preventive chemotherapy to stop the spread of infection. The global baseline estimated of people affected by lymphatic filariasis was 25 million men with hydrocele and over 15 million people with lymphedema. And at least 36 million people remain with these chronic disease manifestations. Eliminating lymphatic filariasis can prevent unnecessary suffering and contribute to reduction of poverty. That is World Health Organization in 2021. Again, in 2022, actually, World Health Organization conducted the Mass Drug Administration in the sub-Saharan Africa for patients with lymphedema. Their target was actually 4 million people, and they achieved 99% of the same. So we have a role to play here. You see how busy it is. Lymphatic filariasis is caused by infection with parasites classified as nematodes, roundworms of the family Filariidae. And there are 3 types of these thread-like filarial worms. The first one is Wuchereria bancrofti, which is responsible for 90% of the cases. Brugia malai, which causes most of the remaining cases. And then we have Brugia timori, which is also a cause of the disease, but in rare aspects. This is a life cycle of the Wuchereria bancrofti, which causes 90% of this disease. So these are the adult worms, and they produce microfilariae. Now this is the first stage larva. Now let's understand this image quite well. We have man here and we have mosquito. The mosquito is the intermediate transmitter of these worms. So once the mosquito feeds on those bacteria and sting on your skin, they deposit those worms into your body, which now produce these microfilariae. And now this one, they multiply, causing millions of them in your lymphatic vessels. Eventually, they end up blocking the system. Now, this is how the worm has the first stage larva, the stage 2 larva, and the stage 3 larva stage. And once the mosquitoes are infected with microfilariae by ingested blood when biting an infected host, the microfilariae now mature into ineffective larvae within the mosquito. So that is what we actually get now deposited into the human body. Now, when the infected mosquito bite people again, mature parasite larvae are deposited on the skin from where they can enter the body. The larva then migrates into the lymphatic vessels where they develop into adult worms. Adult worms nest in the lymphatic vessels and disrupt the normal function of the lymphatic system. The worms can live for approximately 6 to 8 years, and during their lifetime, they can produce millions of microfilariae, as I said earlier, which is immature larvae that circulates in the blood. Now, the lymphatic filariasis is transmitted by different types of mosquito. For example, by the Culex mosquito, widespread across urban and semi-urban areas, the Anopheles, mainly found in rural areas, Aedes, mainly in endemic islands in the Pacific, also in the coastal region. So this is one of our patients who is still managed for lymphedema with lymphatic filariasis and hydrocele. We could not display the photo of the hydrocele for the privacy of the patient. And this is just a tabulation of the important causes and the pathogenesis of secondary lymphedema. That's what we said, the cause and the pathogenesis and how it happens. So we have filariasis, which it's a pro-inflammatory milieu of an injury to the lymph vessels. Once those microfilariae are deposited into your skin and migrate to the lymphatic system and start multiplying in there, within few months, actually, you're going to start already getting the symptoms. But remember, we said that it can stay in your bloodstream from 6 to 8 years of age, and that is a really long period duration. By that time, they might have caused now the leg to look like an elephant, and that is why people say elephantiasis. We have cellulitis, we have tuberculosis, lymphogranuloma, and we have large tumors which put pressure on lymphatic vessels. Sometimes it's not necessarily that you have had a lymph node dissection. Sometimes you can just have large tumors like the lady we had in the earlier photo. They did not even do the lymph node dissection, but that lady had edema because of the pressure on the lymphatic vessels. We have the spread of cancer metastasis, which overexpresses of lymphogenetic growth factors. They include the lymphatic endothelium to produce chemokine filaments that attract tumor cells to lymphatics. Now, increased lymph flow and tumor dissemination by increased contractility of the proximal collecting lymphatic duct. So we have treatment for malignancy. We have the chemotherapy. We have radiotherapy, which sometimes also causes the skin to harden and fibrotic. We have trauma and tissue damage, lymph node excision. Now that's where we have burns, those that work in burns areas. We've seen this, scarring, varicose vein surgery, vein harvesting, and large wounds. They damage the lymphatic vessels and compromise the lymph flow. So we have the venous diseases. We have CVI, venous ulceration, post-thrombotic syndrome, and intravenous drug use. Then under inflammation, we also have rheumatoid arthritis. We have dermatosis, including epidermal dermatosis, psoriasis, and sarcoidosis. Obesity is a very big thing here. External compression of lymphatics by external compression of lymphatics by adipose tissues, increased production of lymph when you are obese, direct injury to the lymphatic endothelium by changes in body weight or diet, lymphedema-associated fat deposition, which is chronically inflamed and infiltrated by macrophages and lymphocytes. We call it lipedema. And then we have increased production of inflammatory cytokines in obese. So we have also a role to play in our obese patients, those ones they are actually at a risk of getting lymphedema. We have immobility, which is lack of muscle activity. Susie earlier explained that muscle activity is one of the pumps that we have in lymph flow. And so that actually massages fluid into along lymphatic vessels, leading to stagnation of lymph fluid. So if you do not move, then how are we going to have that fluid move all the way back? Then we have pretibial myxedema, obstruction of dermal lymphatic vessels and missing, factitious lymphatic compromise from prolonged pressure, and podoconiosis, another bacteria which affects the lymphatic system. Now, education here is not the filling of the bucket, but the lighting of fire. Yeah, let's see that image, and that is our take home today. Let us keep on studying on these webinars. We're going to have a series of webinars. The next session is going to be about the combined decongestive therapy, lymphedema management, and then the need for multidisciplinary team. And we are going to be having another session of surgical lymphedema management. And thereafter, we are going to be having bilateral lymph swelling. And vein and lymphatics, a family affair. So I'm going to toss the mic back to Dr. Cedric Tumbo to take us from there. Thank you very much, Tim.
Lovely, lovely, lovely. Thank you, Janet. Thank you for a very precise presentation. I don't know now. Let me see if we have any questions in the comments now. Somebody is asking, so this will go to any of us. Nowadays, different types of cancer cases are increasing with abnormal speed. Failure of lymphatic system doesn't play any role. So that is George Mungania is asking if failure of the lymphatic system, if it plays any role. I don't know if Susie, you want to take that, and then yeah.
So is the question, does the failure of the lymphatic system play a role in the development of different types of cancer? That's interesting.
Mm-hmm.
So I suppose that's something we would have to research more to give a proper clinical response to that, research-based response. But I suppose anytime the lymphatic system or inflammation is not managed properly, it could lead to a disruption in the way your body produces cells. So I suppose if you're looking at it from that perspective of the immune system not working properly, the answer probably is possible. Yeah. It's definitely possible, yeah. But I think more so it's that once the cancer does happen and the complications from the surgery and the treatments is what then causes this condition of lymph congestion. That is a big side effect of any cancer treatment.
Yeah, thanks. And I think maybe just to add on to that, I don't think necessarily, from what I'm getting from this question, there are cancers that spread primarily through the lymphatic system. It's a primary mode of cancer transmission. So let me say metastasis or anything. So that is proven, that we know that certain cancers do spread through the system. So it's not necessarily a failure of the lymphatic system. It's actually the lymphatic system working. It's only that now, once these cancer cells propagate to the lymphatic system, then this enables the cancer cells to reach other areas that were not necessarily involved first. And that's what we term as metastasis, just to put it in simple terms. Yeah. Let me see if there's any other question. Okay, an anonymous attendee says, how is the role of plastic and reconstruction surgeon on salvage surgery? I don't know, Janet, would you want to?
Oh, yeah. What was the question again? The role of plastic and reconstructive surgeon in salvage. So yes, we are going to be actually having Professor Nangole coming in to talk about, he is a plastic surgeon, and he will be explaining to us more about the surgical management of lymphedema and the reconstruction procedures that they do for these lymphedema patients. So I think you can hold your patient anonymous attendee for Professor Nangole.
Very agreeable.
Yes,
then Wilfred Moretti, why is compression and drainage therapy contraindicated to cancer patients who haven't started treatment? Janet?
Yeah, so I said in advanced stages of cancer, especially stage 4, stage 3B cancer. So basically, if your patient has not started treatment, and cancer at stage 4 is actually the verge of spread, then yes, now that way we are going to be the ones causing more harm to the patient by draining lymphatic fluid and redirecting to the other areas which are probably not affected by those cancer cells yet.
Yeah.
Can I
Anything to add, Yusuf? Yes.
I think it's always the conversation can be had with the doctor, the treating doctor, and the patient. And if the patient's quality of life is affected, and the pros versus cons of providing compression to give patient comfort, if they are at stage 4 where they are in a palliative situation, patient, it's a patient's right and a choice to discuss that with the doctor or surgeon, that if compression will improve their quality of life, it is an acceptable practice. So I'm not sure if that's the type what the question was asking.
I think that contributes still, and yeah, I think that I agree with that. Yeah. So there's another question. There's a good question here. So Wilfred is asking, why is compression and no, that's the one we just answered now. So there's a question here. Are there any supplements that can improve the lymphatic system? And is there circumstances where lymphedema does not go away completely?
So I can answer from our perspective. There are several different natural remedies. We didn't mention any in this talk. And Janet, I don't know if you're going to be mentioning any in the other series of webinars that you're planning. But certainly once you do the research, there are different natural remedies that do support lymphatic health. I'm not mentioning any here. They should all be research-based, studies to show any recommendations. But the other part of the question with regards to the compression, do you mind repeating that?
The question was, why is compression and drainage therapy contraindicated in cancer patients who haven't started treatment? I think that Janet addressed. And then the other one, I think it was just supplements that can improve the lymphatic system. Yeah. So I think we'll also, Janet, I believe we'll also, I think this will be addressed also later
Yeah.
on the management side of the lymphatic, or rather lymphedema. So I think whoever is asking this could also just stay tuned, unless you want to add something.
Right. I see that the question with regards to, are there circumstances with lymphedema does not go away completely?
Yeah, yeah.
Yes. Yeah.
Oh,
So
yes, yes.
that's a very important question, because there
Yes.
is no cure for lymphedema. And I think that's our biggest push about lymphedema awareness, is that once a patient has it reaches the lymphatic system is not working properly, when they start to develop a lymphatic congestion, especially there's different stages, which we haven't, the classification of there's stage 1, there's stage 0, then stage 1, 2, 2B, and then stage 3 lymphedema is when it's elephantiasis. So at stage 3, and even at stage 2, there's no cure for those stages. You can just reduce the edema and then manage it. So this is where it's so super important that patients in this day and age, if you know you've had surgery where the lymph nodes have been removed or radiation, every patient is at lifelong risk to develop lymphedema at some point in the future. And in my clinical practice, when for 15 years, I was practicing a multidisciplinary clinic that I owned in Miami, Florida. We often saw patients who had surgery and radiation from 20 years ago, never had any swelling, nothing. And then all of a sudden they did something, they went on an airplane flight, or they started moving heavy furniture, or they did something that triggered a lymphedema, and then it started swelling. But because it was so long past their cancer diagnosis, first they're tested for blood clots, because that's what you would assume an initial swelling and pain would be. No blood clots. So then the patient's doctor just says, well, I don't know what you can do for it. Here's a water pill. And then what happens? You take a water pill, it pulls more water out of the protein-rich edema and makes the lymphedema worse. So there's no cure for lymphedema. So it's really important to create awareness around, if patients are swelling or having an inflammatory process, to try to connect them with a certified lymphedema therapist that will ask all of the right questions to find out what's the etiology of the swelling, and then to safely initiate manual lymph drainage, which could help reduce the swelling, and then if needed, do compression bandaging, and then long-term compression with compression garments or Velcro wraps, or teach the patient to bandage themselves. So there's no cure for those types. It's only management. But the earlier stages, you don't want to say cure, but you can reduce the edema so that it's manageable and then it doesn't return. And then as soon as the patient feels that they're starting to swell again, to go to the lymph drainage therapist, or learn to do their own self-massage, their own manual lymph drainage, their own breathing exercises, their own stimulation, and watching their diet and wearing compression. And so that it could be medically managed, but not really cured.
Lovely. Thanks. I think that that addresses that. Which other question here? There's some questions that are not really related to this. Let me look at. So Mildred says, if you get someone who had a swollen leg for a period of time, who says it started when she got pierced by a stick, can we group it as lymphedema or cellulitis? I think I'll take this. I think we now know what lymphedema is. Now, cellulitis on the other side is it's infection of your skin. I would say up to just the rectus. So this we know the causes of lymphedema now. Now these are two entities that we could say maybe cellulitis could lead to lymphedema if we get to damage our if the damage gets to the lymphatic vessels. But those are two different entities, and I don't think they should necessarily be confused. One could lead to the other, but they are two different entities. So depending on what caused what, it would be good to know that cellulitis would be an infection that you need to treat, and lymphedema is more of a progressive thing. You just don't end up with it one day or anything like that. And then, so these other questions, I think these are not questions. I would say these are not questions for this forum. Okay, what is the relation between lymphocytes and viral infections? I don't think we are addressing that today. And then is just, I think we've addressed that. In a full hemogram report raised by lymphocytes indicates those are, we are not necessarily looking into full hemograms today. But yeah, I think those are more, or Janet, you want to say something?
Yeah, well, it's a hemogram. So if there's actually lymphocytosis, which is, the raised lymphocytes, that I think indicates your immune system is actively responding to a threat, or there's an infection or inflammation. Now, when it's hemogram, you want to check, the level, that is basically the white blood cells, the response in the full hemogram. So it's not lymphedema, but yes, now what that means in a full hemogram is that your immune system is probably in a threat. It's facing some immune reactions.
Yeah, thanks, Janet. And now that you've looked into that, I mean, it could mean a lot of things. I think it's important to know that we don't necessarily treat lab results. So depending
Yes,
on
yeah.
when and the way it's raised, that's why it would appear that I'm pushing that question away, but
No, don't push.
we are not, that falls on another forum if we are going to discuss the full hemogram and everything.
Can I make
Yeah,
one thing? With regards to the cellulitis infection, definitely two different diagnoses. However, clinically speaking, often you'll see a patient they have no lymphatic, never had lymph nodes removed, never had surgery, right? And then all of a sudden they get in a cellulitis infection, they get hospitalized. Well, what happens with the cellulitis? They have swelling. And sometimes if that swelling if they're not instructed to go into a long-term compression garment or be bandaged to reduce the swelling once they're medically managed and the cellulitis is under control, then it just sits there, right? That swelling kind of, it hasn't been reduced to its normal site. And then what happens, because they don't have all of that edema out, a few months later, boom, they develop another cellulitis infection. And now they are in this cycle where often you'll see in hospitals patients with recurring cellulitis just out of the blue. But each time they go in, the swelling reduces, but not 100%. And so now it is a lymphatic system failure. And again, this goes to lymphedema awareness. If they're referred to a lymph therapist, that will just educate them to do lymphatic drainage and be bandaged to reduce it back down to normal, because their lymph system is intact. It's just not working at 100% because the infection that was in their body. So then it can create more complications down the road, and then potentially even wounds develop, and then then they can have maybe another etiology of venous insufficiency. Now the cellulitis and the edema is there, and then it creates this false sequelae of events that happen. So this clinically speaking, we see often in a lymphedema clinic. So it's not that they initially didn't have a lymphatic system problem, but they developed a congestion that wasn't removed properly, efficiently, in a timely manner. This is where rest, ice, compression, and elevation wasn't effective. They needed a little bit of something else. And so, and no amount of water pill is going to remove it, because it's now protein-rich fluid. So in fact, a well-intentioned GP or doctor is giving a patient water pill for their swelling, again, might make the condition worse. So it's important, again, to connect with a certified therapist that can help guide the patient appropriately. I think that's the main thing.
Yeah.
And also, Dr. Cedric, in addition of that, if your patient came, because what I'm actually getting from Mildred particularly is she got this patient with swollen leg, and then she was like, it started when I got a prick, or it's a stick. It's basically not anything clean. And that is the major goal here is actually understanding lymphedema, and also I think when we are doing, when Susie is doing the management, because we are going to be doing staging, she's also going to be doing the differential diagnosis, so that you do not treat something that you think is lymphedema when actually needs to be managed by another healthcare professional before they land into you. So when maybe that patient was pricked, but how long also has it been? There are very many things that we need to factor in here, because for us to classify as cellulitis, is it painful? When was the prick? Is it acute? Is it chronic condition? did it start immediately after the prick, and did it not just go down? Was, those kind of information. So I think let's stay tuned in. Let's really understand what lymphedema here is, what we are dealing with, and that is why we have professionals from the multidisciplinary team, so that we can also learn how to differentiate it. I think also Dr. Cedric is going to be talking about that when he's going to be doing his presentation. Yeah, but that was a very good question, Mildred. Just check, take a bit more of history with your patient and find out exactly what happened. Did she even get a medical attention after that prick? Because it didn't just prick and go away. After a prick, you'll bleed, and of course, there's going to be maybe an opening for a while. What type of medications did she use? And why didn't the edema go down? Are there any tests that were conducted to rule out this condition?
Yeah.
Lovely.
So I don't know, we can take maybe one more, or we still do have time?
Wow, we have 3 minutes.
I think we have 3 minutes. So there's a question on management. I think we'll have a session on management too, right?
This is on management.
Okay, so here goes the question. So what is the most appropriate approach in management of radiotherapy-induced lymphedema?
So the question is with radiotherapy and management of lymphedema?
Yeah, so like a patient who has undergone radiotherapy-induced lymphedema.
So it is, again, if the oncologist or the radiation oncologist is in agreement, and again, it comes down to, is it affecting the patient's quality of life, right? That oftentimes when a patient initially starts with the radiation therapy, depending on how long or how many weeks or months sometimes they have to undergo the radiation, the edema starts to occur. So a patient can undergo the lymphedema therapy, safely have manual lymph drainage, and the compression bandaging while they're undergoing the radiation. We have had patients have it concurrently. It just depends on the medical team and their approach and the patient's, you have to have the full patient's history and diagnosis that you can safely proceed. But oftentimes the referral is because the edema that's forming from the radiation is causing an impact on their quality of life. The arm's becoming heavy, they're losing function. So if the lymph therapist can help reduce the edema, that increases their function and their less pain, that's usually the approach that I've seen in the medical community.
Yeah, Janet, you want to add something?
Okay, so yeah, on that, radiotherapy, I think most of the patients I receive also they are receiving radiotherapy treatments, and now the most appropriate approach here, I think, Susie, I would actually say, I think it depends also on the stage, as Susie has explained. But yes, if it's a patient who is having the lymphedema setting in, the most appropriate way is actually to do a compression sleeve. Sometimes when patients are undergoing radiotherapy, the skin is so sensitive because of the radio waves, and also even doing manual lymphatic drainage, even though it's so superficial to the skin, sometimes the skin is so sensitive for that patient even to touch. So I would actually say this also depends on those that are undergoing radio, most of the time I receive them early. And if I do not receive them early, then I receive them after they have already done radiotherapy and the accumulation is, the lymph volume is too big. But so that we are all safe, the most appropriate one here is let's do the sleeve. If we can do the compression sleeve, because that is not going to be interfering with the skin, tell a patient not to scratch because of the waves, the skin is so sensitive and it's so light. You can even easily cause a wound in that radio area. And we know very well, especially when patients undergo chemotherapy, they are going and then surgery and then radio, there is less granulation of tissue because of the effects of chemotherapy, and we do not want to be causing more problems to these patients. So we go with compression garments in this case. That is the most appropriate one. And exercise, because exercise is not going to beat your skin out. Advise patients to move their limbs. If it's the lower extremities, also moving, doing some active exercises, and draining now the areas that are not exposed to the radiotherapy. That one would really work perfect.
Because we'll be talking about the management, which is called combined decongestive therapy. So when we're stimulating the lymph system, if there's a swelling in the arm, we're actually stimulating the other areas where there's healthy lymph nodes. So you actually don't even need to treat or touch the swollen area. You're decongesting and creating a pathway for the lymph fluid from the swollen area to be rerouted to healthy lymph node areas. So that way you can teach a patient to do self-lymph drainage. And then, of course, like Janet said, the compression that keeps the swelling under control as best as possible. And the diaphragmatic breathing that I taught you earlier today, too. Don't forget the diaphragmatic breathing should be taught to each patient. And then watching their diet as well. And, of course, they need to watch that they're not eating too much sodium while they're undergoing, because sometimes people's diets are high in preservatives and refined foods. And so the healthier they eat, the less they're retaining fluid as well, and they should be drinking more water, as long as they don't have kidney issues. And that's
lovely. So I think what I'm getting is there are principles to this that literally are standard. So it's only the approach that will differ depending on your patient. And I think that's the message you're trying to get through.
Correct.
Lovely. So I think that's I don't know now. I think I'll probably will get a final word from both of you. I think who wants to go first? Maybe Janet, you want to go first? No. We'll let Susie.
And since we are making noise and creating awareness with the lymphedema series, I know the person of the marker, I think Cedric will be able to answer you about a test they send patients, lymphoscintigraphy. But this one who asked, is lymphedema considered a disability? Abdurizak, yes. Lymphedema, if unmanaged, can disable someone. That is the discussions we are having, and that is where we are making a lot of noise and creating awareness, advocating, educating for early detection and early management. And let's run with this awareness.
Yes.
Lymphedema is no longer rare. It's very common. For my few years of practice as a lymphedema therapist, I have seen that there are many. They just don't know what is this. So lymphedema is considered a disability. Yes.
It is. I agree. And in fact, primary lymphedema is categorized as a rare disease, right? Because it's a small population of people who develop or are born with a deficient lymphatic system. Most common, you're going to see secondary lymphedema. People are developing this swelling that's not being managed early and not being referred for the edema control early. And this is why they're developing secondary lymphedema. So awareness is key. I do think it's a completely underdiagnosed condition because doctors are not diagnosing that there's a lymphatic system dysfunction. So the more we can create, the more awareness and the less people are going to suffer with this debilitating swelling that can occur. And so we're looking forward to making a difference in the world. So thank you all for coordinating this beautiful webinar. And hopefully we've been able to create a lot more awareness for all the participants that are on the call today.
Yeah.
Thank you. Thank you, Dr. Cedric. You're a great facilitator. Thank you.
Thank you, Susie. Thank you very much. And I think those are very good turnout today. I hope you guys will keep.
I see there are very many questions about management, Constantine.
Yeah.
And I think you can actually carry your management questions to the next presentation we are going to be having next week on Thursday.
It's next week.
Yeah, it's next week on Thursday. And I think also there are very many questions for Dr. Cedric. Combination actually for Doppler, DVT, rivaroxaban, and all that. So yeah, we are going to be able to answer all these questions to you in the upcoming series. So thank you so much, Dr. Cedric. I'm going to hand over to you now so that we can finish.
All right. Thank you, guys. I think today's message is home. So as I was mentioning earlier, I hope we'll see the same numbers in the upcoming series. There's a lot of information. Personally, I'm learning a lot. Yeah.
More numbers. We want more numbers. Let's get to 1,000 next time, because we are creating awareness, guys. We are creating awareness here. We are advocating for early management and detection and management. So share widely once we share the posters, so that other people, even in the county, community health volunteers, let people understand what this is, and let us have these patients well managed.
Indeed.
1,000.
1,000. Let's go.
1,000. Let's get to 1,000. Okay. Thank you from my side, and looking forward to seeing you guys next Thursday.
Thank you so much.
Bye-bye. Have a lovely weekend. Bye-bye.
Bye.